Today, we are joined by Dr. Syed Raza Saurav Acharya and Gabrielle Howard as they discuss the safety of recombinant zoster vaccine in patients with rheumatic diseases, a topic they address in their article that appeared in the February 2022 issue of the Southern Medical Journal. Thank you all for being here.
Thank you for having me.
Thank you for having us.
Thank you.
Herpes zoster or shingles affects 1 in every 3 people during his or her lifetime, and the incidence seems to be higher in the older adult population. Patients with rheumatic diseases are found to be at higher risk of herpes zoster. Could you tell us a little about shingles and explain why these patients are at higher risk?
Sure, thank you. So I'll answer this question. So varicella zoster, as I think we're all essentially familiar with, is broken down into the primary and then the secondary infection. So the primary infection for most people occurs during childhood, and that's what we colloquially refer to as chickenpox. So during the primary infection, virus will actually establish latency in sensory ganglia. So once the immune system, and specifically it's the T cell mediated immunity that gets that initial infection under control, as well as keeping the virus at bay in the sensory ganglia over time. But it is, once you've been infected with varicella zoster, it is always there in the background. And as I said, it's the T cell mediated immunity that's responsible for suppressing that. But to speak to the age risk factor, so with time, as we age, our T cell immunity does wane with time, and that's referred to as immunosenescence. And so that's why we see in older people, typically that's when the virus will reactivate and cause a shingles infection. So when you look at our rheumatoid arthritis patients, for example, a lot of them are older, and so they're going to be carrying that age risk factor with them. But to speak to the other piece, which is even younger patients with autoimmune diseases have a higher risk. And we don't have exact details on that, but it seems to be related to that inherent deficiency, either in their cell-mediated immunity or some portion of their immune system that is dysregulated, as evidenced by their autoimmune disease. And specifically, this has been looked at in rheumatoid arthritis patients, lupus patients, and inflammatory bowel disease patients. And there's consistent data to see a higher risk. If you look at lupus patients, you'll see varied numbers in terms of how much that risk is increased. But it seems to be at least around a 2-fold increased risk. And then you'll see some studies that report it even at 10 times, which may be a little higher than it actually is. And then in the rheumatoid arthritis patients, typically anywhere from about 1.5 to a 2-fold increased risk incidence of herpes zoster is what you'll see in the literature there. And then furthermore, in our patients, as we know, we give them immunosuppression to manage their disease, and that is going to increase their risk even further. Now, if you look at the literature, you'll see a lot of variations again in terms of drug classes, DMARDs, biologics. One thing that's very consistent is that glucocorticoids increase the risk of herpes zoster, and that increases further as the dose gets higher, specifically beyond about 10 milligrams of prednisone, you're going to see a significant upkick in risk. If you look at the DMARDs, it is very varied, with some studies suggesting that there isn't much of a higher risk, and then others that there are. So specifically, there's one study that was done actually a while ago in 2006 by Wolf et al., but it compared several DMARDs in rheumatoid arthritis patients. And that study showed with leflunomide, for example, a hazard ratio of 1.4. And then with azathioprine, a hazard ratio of 2. Now with the azathioprine in that study, they acknowledged that might be a little higher than it actually is. And that was due to a small sample size. And then beyond the DMARDs in that study, they also looked at cyclophosphamide, which as we know is a much stronger immunosuppressive drug. And with that one, they found a hazard ratio of 4. And then there's been more recent modern studies comparing DMARDs to TNF inhibitors, as well as other biologics such as rituximab, abatacept, and tocilizumab. A more recent study by Pappas et al. Commented that between those classes that I just mentioned, there seemed to be kind of a similar increased risk. And then another thing that has been demonstrated in multiple studies, and again is really not debated, is that tofacitinib, a JAK inhibitor, definitely seems to confer a higher risk of herpes zoster, and that's in comparison to other biologics. So that the way I see it is that if you look at a rheumatoid arthritis patient, for example, they may be older to begin with, they have an autoimmune disease, and then they're on immune suppressive medication. So they're very high risk.
Thank you for providing some background on that. Recombinant zoster vaccine is FDA approved for the prevention of shingles in adults 50 years of age and older. However, immunocompromised subjects have been excluded from vaccine trials. You have studied the safety of this vaccine in your university-affiliated rheumatology practice. Could you please share some of the details of your study and its design, and what led you to undertake this study?
So I'm going to take this question. Dr. Howard had already mentioned that why our patients are at higher risk of shingles because of nature of the disease itself, and also being on immunosuppression medication. And medications, something we've thought are more of immunomodulator than immunosuppressant, something like hydroxychloroquine was also found is the risk of shingles in one of the studies in 2017. So when this vaccine got approved in 2017, we were very excited about possibility of vaccine in our patient population. However, our patient population was excluded from in the trial. One of the possible reason is high reactogenicity of the vaccine, that up to 70% patients some kind of reaction, and 10 to 12% of patients in phase 3 trials had a severe reaction, and 30% of the severe reaction constituted pain, myalgia. So a lot of our diseases, arthritis or muscular pain is a part of the disease itself. So there was a concern around at that time about if the vaccine could flare up underlying rheumatic disease among our patients. So yeah, that was the reason to answer this, whether vaccine is safe or not in our patient. And that was the reason why we initiated the study. As we know, this was a study, a retrospective study done on our patient who in 2018 who had received vaccine, and we collected all the demographic data, medication use, and we collected C-reactive protein and a rapid 3 score before the first dose of the vaccine and after the second dose of the vaccine to compare whether their C-reactive protein, which is an inflammatory marker, has increased after the vaccines, or their rapid 3, which is a disease severity assessment scoring mainly used, validated in rheumatoid arthritis. However, we did have a data for rapid 3 scoring for most of our patients. So we did compare that before the first and after the second vaccine to see whether the disease activity score increased, which would reflect higher disease severity after the vaccine. And among the medications, we also looked into their prednisone, which is a steroid they were taking. The baseline dose, did that increase before or after vaccination? So we did have 47 patients who received both vaccination, both doses of vaccine, first and second. And so we did have all sort of rheumatic disease, but 76% of patients had rheumatoid arthritis. So overall, we did not find any increase in rapid 3 score or C-reactive protein on this patient before or after vaccination. There was no statistically significant increase in the scores. And we did not find any difference in the dose of prednisone before and after vaccine as well. Among our patients, 6.4% had reported adverse reaction, but none of these reactions were severe enough to warrant hospital admission or cause major organ failure or death. So we concluded that recombinant zoster vaccine was safe and well tolerated among our patients in our practice.
Were any of your findings, any of the results, were they surprising to you?
I will take that question and the next couple as well, if there are any. So before we started vaccinating our patients, and as Dr. Acharya alluded to, that vaccine got approval in 2017, and we were very excited based on what Dr. Howard mentioned, the risk that our patients are at. So, but before we started vaccinating the patients, just like Dr. Acharya mentioned, that there is a relatively newer adjuvant that is used in this vaccine, which seems to be very irritating to the immune system, which is, of course, by design. You want your immune system to respond well to the vaccination. So the concern was that what if this new adjuvant can cause disease flares? So yeah, there was a little bit of concern before we started the vaccination of our patients. But since all those patients belong to our clinic, so we had seen those patients throughout the year. So during all those encounters, we didn't see any significant adverse reactions other than, maybe local pain or fever, achiness in the body. And none of those reactions were severe enough to cause significant concern. And in terms of disease flares, we did not see the disease flare in our normal encounters with the patient. So once the study data was collected and we had the results, it really wasn't surprising, because during our day-to-day clinical practice during 2018, we did not see that. Now, following that, now we're in 2022, because the study was for the patients in 2018. So since then, we are still vaccinating our patients. All the patients who agreed to get vaccinated and whose insurance would cover the vaccine cost. I mean, you would be surprised that, unfortunately, even though it is FDA approved, sometimes the cost of the vaccine and the co-pays are so high that the patient can't afford it, unfortunately. So, but all the patients who were willing and were able to afford the vaccine have been getting vaccinated for the last 4 years since the study ended. And even then, I have not seen, or we have not seen, any significant adverse events or disease flares. So that really also indicates that the vaccine is relatively, safe in our patient population.
What else would you like people to know regarding RSV vaccine as it relates to this patient population?
Okay, let me bring a few points which can be interesting to our listeners and in the general population as well. So more than 99% of the Americans born on or before the 1980, they have had chickenpox, even if they don't remember having the disease. So you can get vaccinated whether or not you remember having had chickenpox in the past. So that's important to understand, because some patients have that question. Now, even if you got the chickenpox vaccine, so you were born after 1980 and because of the childhood vaccination schedule, so the chickenpox vaccine is very effective, it's up to 90% effective, but even then you could still get reactivation of varicella virus and can get herpes zoster. So even then, if you have had chickenpox vaccination, you could still get herpes zoster vaccine. So that's another important point to remember. Then the third thing that I was really happy about happened last year in summer of 2021, I think around August, maybe summer, fall. FDA approved this vaccine for any adult aged 18 and above who is either suffering from an immune deficiency or is at risk of immune suppression due to an underlying disease or treatment. So in my view, that was a significant advancement, because I have had young patients and my colleagues have had young patients on immune suppressive medications who have developed shingles, even when they are 20 years old or 30 years old. And we have known patients who have developed shingles on multiple parts of the body, which can be really problematic. So, so some of my young patients, even before FDA got this approval, they actually paid out of pocket and got the vaccination because they were so concerned that they might get, shingles while on these immunosuppressive therapies. So that's a very good step in our patient management. Then in October of 2021, so ACIP, which is the body under the CDC, which recommends immunization practices. So they actually also endorsed that guidance or approval from FDA. However, they kept the age at 19. So FDA approval is for 18 and above if you're immunocompromised. ACIP is recommending same, but they say 19 years and older individuals. So that's that's an excellent improvement or availability of this vaccine for our patients even younger patients who need it.
This has been a really informative discussion, and I would like to thank each of you for your time today. Before we conclude, are there any additional thoughts any of you would like to share with our listeners?
Yes, few other points. So what's the best time to vaccinate our patients? So the best time to vaccinate is before starting the immune compromising medication. So that is the best time. However, if the patient is already on immunosuppressive medication and you want to vaccinate them, so then the best time is when the disease is under control. So when they're not having active lupus or active rheumatoid arthritis and all, when the disease is relatively under good control, that's the time you should vaccinate them. Then number two, there are certain medications which tend to portend higher risk of herpes zoster than others. For example, Dr. Howard mentioned prednisone, corticosteroids, dose of 10 milligram of more. Then the Janus kinase inhibitors like tofacitinib, baricitinib, or pedocitinib, medications like mycophenolate mofetil. So these medications have higher risk than other medications. Number three, there are medications like rituximab, which work to deplete B cells in our immune system, which of course, convert into plasma cells, and they produce antibodies, which we need to have a response against the vaccinations. So if the patient is on rituximab already and you were not able to vaccinate them before they started the treatment, so the best time to give them the vaccine according to the CDC guideline is 4 weeks before they are due for the next dose of the rituximab. So that is the best time to vaccinate them. And then another important point is that if the patient has developed shingles and they have not received the vaccination beforehand, then you can vaccinate them as soon as the shingles lesions are crusted. So you do not have to wait any longer than that. As soon as the lesions are crusted, you can go ahead and vaccinate the patient. And finally, it's important to know that the vaccine was not studied in pregnant patient populations. So we just do not know if we can vaccinate that population.
Thank you again for your time today. I think this has been a very informative and beneficial conversation to have, and our listeners will get great benefit from this. So I thank you all.
Thank you for having us.
Thank you. We enjoyed it.